We're going to talk about thyroid gland in this video. This presentation is mainly aimed at nurse practitioner students and nurse practitioners. In this video, we are going to talk about the functional anatomy of the thyroid gland, how T3, T4, and reverse T3 are produced in the thyroid gland, and how body utilizes the T3 and T4. We'll also talk about the hypothalamic, anterior pituitary, and thyroid axis. What are some of the negative feedback mechanisms? And how do we read the thyroid function test, including thyroid antibodies? At first, let's talk about the very basics of functional anatomy of the thyroid gland. This is a piece of thyroid gland tissue. And in the middle, what you see is a follicle. Follicle is a functional unit of the thyroid gland. And follicle is made of cells called thyrocytes. So these individual ones are thyrocytes. And these thyrocytes are arranged in such a fashion that it makes follicle. And in the middle of the follicle, you will see a space, a lumen, or this is called a lumen. A lumen contains a liquid, a substance called colloid. Now, other than the thyrocytes, there are also a few other cells present in the thyroid tissue. And those cells are called parafollicular cells. And these parafollicular cells are responsible for producing calcitonin, whereas the thyrocytes or follicle are responsible for producing thyroid hormones T3 and T4. Now this is an individual thyrocyte from the follicle. Okay? And if you look at here again, this is one thyrocyte. And this side of the thyrocyte, this layer is called basal membrane. And basal membrane contains mainly two things. I only drew one. This is called an iodine sodium pump. What it does is it takes the iodates from the blood and put this across the basal membrane into the thyrocytes. There's also one more thing in the basal membrane called TSH receptor. Now we move across to the luminal membrane, and luminal membrane contains an enzyme called thyroid peroxidase. Now let's see how T3 and T4 are formed in the thyroid gland. This is one thyrocyte, and here is a blood vessel, and the blood carries the iodates, and here is the sodium iodine pump. And as I mentioned before, that there is one more thing here on the basal membrane called TSH receptor. And now the TSH receptor will be stimulated by the TSH. And once the TSH receptor is stimulated, there will be a cascade of chemical reactions will take place within this thyrocyte. And the end product is called protein kinase A. And the protein kinase A has multiple functions. At first, it stimulates the iodine sodium pump. Once this is stimulated, there will be iodates will be moving from the blood into the thyrocytes. Once the iodates moves into the thyrocytes, it will move towards the luminal membrane. And what we have here at the luminal membrane is TPO. The TPO will convert the iodates into iodine. And once it is converted, this will be put across the luminal membrane into the lumen, where we have colloid. So now iodine is present in the colloid within the lumen. Now protein kinase A, what it does next is it stimulates the DNA. Once the DNA is stimulated, it will produce something called a messenger RNA. The messenger RNA contains or carries the genetic information from the DNA to the ribosomes. So this messenger RNA will take the genetic information from the RNA to the ribosomes. And what does the ribosomes do? the ribosomes will produce a protein using amino acids, right? So here, under the influence of this messenger RNA, the ribosomes will produce a chain of protein, a protein chain, or otherwise a chain of amino acids, and this protein chain is called thyroglobulin. The main amino acid present in this thyroglobulin is called tyrosine. It's right here. Okay, so it's a chain of amino acids produced by the ribosomes, and it mainly contains an amino acid called tyrosine. Once this thyroglobulin is produced, this will be put across the luminal membrane into the colloid again. Okay, with the process of exocytosis, this will be put across into the colloid. Now, the thyroglobulin is present here in the colloid. Also, iodine is present. Now, what the TPO, the thyroid peroxidase, will do is it will help the iodine to get loaded onto the tyrosine. As I mentioned before, thyroglobulin contains a lot of tyrosine molecules, tyrosine amino acids. The iodine will be loaded into each tyrosine molecules with the help of TPO. Now, some tyrosine molecules will be loaded with one iodine. There will be few other tyrosine molecules will be loaded with two iodine molecules. If one iodine molecule loaded into tyrosine, it is called monoiodotyrosine. If there are two iodine molecules in the tyrosine molecule, that molecule is called diiodotyrosine. So there will be many MITs and DITs in this one thyroglobulin chain. And now the next process is, if the iodine-loaded tyrosine molecules are sitting next to each other, this will undergo a process called coupling. And this coupling is also influenced by the TPO. Now here, one MIT and another DIT sitting close by, and the TPO will enhance the coupling of these two. So what happens is it forms something called T3, otherwise triiodothyronine. Okay, and here if you look at, this is a DIT and there's another DIT, and these two couples to form T4, otherwise thyroxine. So there are a few other tyrosine molecules. This could be loaded with just one, it could be loaded with two, this could form another T3, or there could be other tyrosine molecules loaded with iodine but doesn't have an adjacent tyrosine to couple with. So what happens is there could be an individual MIT sitting, an individual DIT sitting uncoupled. As we know, there are a few other amino acid molecules are also present in this thyroglobulin, but tyrosine is which makes the T3 and T4. So one thyroglobulin chain contains many T3 and T4. Okay, so this will be hanging around here in the colloid. So whenever the body requires, this will get back to the thyrocytes and will get into the blood. Now, we're coming back to that process. As we mentioned before, the protein kinase A, which stimulates the iodine-sodium pump and the DNA, will also stimulate this luminal membrane. So what the luminal membrane will do is, this will do something called an endocytosis. This will stretch out into the colloid, take a portion of the colloid, and colloid contains thyroglobulin, and this will be put into the thyrocyte as a vesicle, and this vesicle contains colloid and thyroglobulin. And once this vesicle enters the thyrocyte, this will be attached by the lysosomes, and the lysosomes will cut down this thyroglobulin chain. Once it cuts it down, it will release the individual molecules. Here, T3 will be released. It will be cut across like this, so T3 will be released. It will be cut here, T4 will be released. There could be uncoupled DITs, there could be uncoupled MITs, and few amino acids also will be released into the thyrocyte. Now, Now the T3 and T4 are free, and now this will move across this basal membrane into the blood. Because T3, T4 are low here, this will move across the gradient. So that is how T3 and T4 are moving to the blood. Now let's recap the function of the TPO. It's so very important. So TPO, it helps the iodates to be converted to iodine. Then this will also help to move the iodine from the thyrocytes into the colloid. TPO helps to load the iodine into the tyrosine molecule. It also helps to couple the iodine-loaded tyrosine. So it's so important. So this is how T3, T4 are formed, and it is released into the blood. Now, once this is T3 or T4 are released in the blood, the body can use it. Now T3, only 10% is T3, and the rest of the 90% is T4. And T3 is the most active form. And as soon as the T3 and T4 enters the blood, this will bind with a protein called thyroid binding globulin. Okay, and this is produced by the liver. So 99% of the T3, T4 will be binding with thyroid binding globulin. And now the rest of the 1% will be free in the blood. So that is called free T3 and free T4. Now only if it is free, it can enter into the cells. Now once the free T3, T4 quantity decreases in the blood, more T3, T4 will be becoming free. So once the free T3 is available, it diffuses into the tissues, into the cells. At the same time, T4 also will be diffusing into the cells. So T3 stimulates the basal metabolism in the cells. So let's see what happens to the T4. Once the T4 enters the cells, it cannot do anything. So it has to be converted to T3 in order to influence the cells or to do anything. Now let's see how T4 is converted into T3. Now this first diagram, this is a T4. This is a T4. Now this is one DIT and this is another DIT. Now look at this DIT. This has two iodine molecules. It is important to understand that this iodine is loaded onto the 3rd prime carbon molecule and 5th prime carbon molecule. And in the second DIT, iodine molecules are loaded into 3rd carbon and 5th carbon molecule, not prime. Okay? Now, there's an enzyme in the cells called 5' monodeiodinase. And what this does is it removes the iodine from the 5th prime carbon molecule. So it removed from here. So there's no iodine molecule here. So this DIT became an MIT. So this MIT and this DIT, this becomes T3. So this is how T4 becomes T3. But unfortunately, there's one more enzyme present in the cells called 5' monodeiodinase. What this enzyme does is, instead of removing an iodine molecule from the 5' carbon molecule, this will remove the iodine from the 5th carbon molecule on the second DIT. So in this case, the first DIT has 2 iodine molecules, and the second DIT became MIT because from the 5 carbon molecule, the iodine has been removed. So now, look at the pattern here. The first one, you have 1 iodine molecule in the first molecule, and then 2 iodine here. But here, it reversed. The first one contains 2 iodine molecules, and the second one contains 1 iodine molecule. So this is called a reverse T3. And once a reverse T3 is produced, the cells cannot utilize this. So it has to be removed by the body. So, in nutshell, T4 is not only converted to T3, it is also converted to reverse T3. The main reason why the reverse T3 is formed is the way to remove the excess T4. But what happens if there is more reverse T3 are produced? If there are more reverse T3 are produced, what happens is the T4 amount will be decreased in the blood. So even though this patient is producing enough of T3, T4, but body is producing more of reverse T3, so patient will be having clinical symptoms of hypothyroidism. So usually 40% of the T4 will be converted to T3. And the rest of the T4 will be converted to reverse T3 and will be removed by the kidneys. These are some of the factors which can increase the production of reverse T3: stress, pregnancy, renal failure, beta blockers, liver failure, excess cortisol, or even cortisol deficiency, and iron deficiency anemia. Now let's look at hypothalamic anterior pituitary axis. As I mentioned before, only 10% of the thyroid hormones are T3. And then whatever T3 is available, it will get into the cells to influence the cells. And 90% of the hormones are T4. And out of that, only 1% is free T4. Once the concentration of the free T4 decreases in the blood, this will stimulate the hypothalamus. Now, this is the hypothalamus, this is the posterior pituitary, and this is the anterior pituitary. And the hypothalamus and the anterior pituitary are connected with the help of a special blood vessels called hypothalamic hypophyseal portal system. So when the free T4 decreases, this will come and stimulate the hypothalamus. And the hypothalamus will produce a hormone called thyrotropin releasing hormone. And that will come down to the anterior pituitary gland and will stimulate the anterior pituitary gland to produce thyroid stimulating hormone, TSH. And once that is produced, it will be released into the blood and will come and stimulate the thyroid stimulating hormone receptor, which is sitting on the basal membrane of the thyrocytes, which we have already seen that, which produces a cascade of chemical reactions and will produce protein kinase A. And we already saw that protein kinase A will stimulate the iron sodium pump. It also stimulates the TPO. It stimulates the DNA. It also increases the endocytosis, which is bringing more colloid and thyrocytes from the lumen into the thyrocytes. So this is how the hypothalamic anterior pituitary axis work. Now let's look at some of the negative feedback mechanisms associated with the thyroid gland. We already mentioned that when free T4 decreases in the blood, it stimulates the hypothalamus. The same way, when the free T4 increases in the blood, it is going to suppress the hypothalamus and will eventually suppress the TRH, which will suppress the TSH. The same way, when you have increased TSH in the blood, it is going to suppress the TRH, the hypothalamus. It is going to suppress the hypothalamus. If the person has an acute iron load, how does it affect the individual? It depends on what is the individual's state of health as far as the thyroid gland is concerned. If the person has a normal thyroid and this person is loaded with iodine, what happens is this excess quick load of iodine will suppress the iodine pump. Once the iodine pump is suppressed, you know what happens? You don't have the iodine to produce T3, T4. Eventually T3, T4 production will be less. Patient will go to a thyroid situation. Now, if the patient has already hypothyroidism or goiter, and if that person is loaded with acute iodine, what happens is all of a sudden this person is getting excess of iodine. So the production of the supply is more, so the production of T3, T4 will be more. So this person becomes, all of a sudden he becomes hyperthyroid state. And this is not going to last long, but at least that person going into hyperthyroid stage. So an acute iodine load can do either hypothyroidism or hyperthyroidism depending upon the state of the thyroid. And a clinical example for this acute iodine load is patients who are getting amiodarone. Amiodarone contains iodine, and long use of amiodarone can cause either hypothyroidism or hyperthyroidism. That's the reason why patients who are getting amiodarone should have TSH checked at least once in a year. Now let's look at some of the labs we will order as far as the thyroid gland is concerned. We will be ordering TSH, we ordered free T4 and free T3. Very, very seldom we do that. We also order the thyroid antibodies. Let's see how we can read these different results. Now we will be looking at the TSH, free T3 and free T4. Now if the TSH is high, that means this is because of a negative feedback mechanism, right? The negative feedback mechanism is if the free T4 drops in the blood, this is going to stimulate the hypothalamus, and the hypothalamus will be releasing TRH, more TRH. So more TRH will be releasing and will be stimulating the anterior pituitary to produce more TSH. So there will be more TSH. So thyroid gland is not producing enough of T3, T4. In turn, it produces a negative feedback mechanism and TSH will be elevated. So you are looking at a condition called primary hypothyroidism. Now here, the TSH, the second one, the TSH is high, but the T3, T4 levels are normal. So this could be a case of subclinical hypothyroidism, or it's a very mild hypothyroidism, and eventually this normal T4 and T3 will become low. Now look at the third scenario. You have free T3 and free T4 are high. That means as a negative feedback mechanism, the production of TSH will be less. That means the thyroid gland is producing more and more free T3, 4. So it is going to suppress the TSH. This is the case of primary hyperthyroidism. Now look at TSH is low. Usually when TSH is low, we think it is hyperthyroidism. But when we look at the T3, T4, those two are normal. So this is again a case of a very mild or subclinical hyperthyroidism, and this will eventually go up. Now another scenario where you have low TSH, low T3 and T4. So that means the negative feedback mechanism is not working. If free T3, T4 are low, what it should do is it should stimulate the it should stimulate the hypothalamus, and it should stimulate the anterior pituitary gland to produce more TSH. But in this case, that system is not working. The central system is not working. That means there is something wrong with the central command. So this is called central hypothyroidism. So in a classic case of hypothyroidism, you will see low T3, T4 and with a high TSH. But in this case, free T3, T4 are low, but this fails to stimulate the central command, that the central command is not working. So all three are low. You're looking at other than some thyroid issues or central hypothyroidism. Now in this case, in this scenario, all these three are high. That means free T3, T4 is high, but it fails to suppress the release of TSH from the anterior pituitary gland. That means there's something wrong with the anterior pituitary gland. There's a functional tumor sitting at the anterior pituitary gland which is constantly releasing TSH. It is not taking a feedback from the hypothalamus anymore. Hypothalamus is only producing less TRH. But unfortunately, there is a functional tumor sitting in the pituitary gland which doesn't listen to anybody and we're constantly throwing out TSH. So more TSH receptors on the thyroid gland will be stimulated. Every time thyroid gland is stimulated, it is going to produce more T3, T4. So if these three are high, you're suspecting some kind of a pituitary tumor, pituitary functional tumor. Now the last scenario, here free T4 and free T3 are high, but the TSH is normal. So if the TSH is normal, means usually everything is normal, all right? Usually everything is normal. But then why free T3 and T4 are high? It is mainly because of the fact that the peripheral cells, the cells in our body, are not taking the free T3 and T4 into them. They're not taking it. They have a very bad resistance to free T3 and T4. Because of the resistance, whatever T3, T4 are produced are going to run around in the blood. It is not entering into the cells. Now, that is why you have a normal TSH and a high T3, T4 because of the peripheral resistance. So these are some of the different scenarios of thyroid function tests. Now let's look at one more thing, which is the thyroid antibodies. There are mainly three types of thyroid antibodies. The first one is called anti-thyroglobulin antibody. And we already mentioned about the thyroglobulin. This thyroglobulin is nothing but this is the amino acid chain which is going to be loaded with T3, T4. And once this is blocked by an antibody, what happens is this is not going to go across the luminal membrane into the lumen to get loaded with the iodine or to form T3 and T4. So what happens is this person is going to have hypothyroidism. So this hypothyroidism, due to the presence of an antibody, is called Hashimoto's thyroiditis. And the second type of antibody is produced against the thyroid peroxidase, which is TPO. So anti-thyroid peroxidase antibody is the second one. So the scenario is going to be the same as the previous one. It is going to block the TPO. Once the TPO is blocked, all the functions of the TPO is going to be blocked. So T3, T4 are not going to be produced. You're going to have hypothyroidism, which is again called Hashimoto's thyroiditis. This is similar to the previous one. Now there's a third type of antibody which is produced against the TSH. And this anti-TSH receptor also blocks the TSH receptor. Once the TSH receptors are blocked, you know that it is not going to produce that chemical reaction. There's no end product called protein kinase A. When there's no protein kinase A, there's no stimulation of the DNA, there's no stimulation of the iodine sodium pump, no stimulation of the TPO, no stimulation of the luminal membrane. So again, T3, T4 production is low, and this hypothyroidism caused by the presence of antibody is also called Hashimoto's thyroiditis. Now the fourth one, this is also called an anti-TSH receptor antibodies, just like the third one. But there are two types of anti-TSH receptor antibodies. One blocks the TSH receptor, and this stimulates the TSH receptor. So when this sits on the TSH receptor, this is going to constantly stimulate the TSH receptor. Once the TSH receptor is constantly stimulated, the end product is more production of T3 and T4. And in this case, negative feedback mechanism is not going to work, because when the T4 is high in the blood, this is going to automatically suppress the central command. The production of TSH will be low. But the presence of low TSH is going to have no impact here because TSH is not what is stimulating the TSH receptor here, rather an antibody stimulating the receptor here. So there will be excessive production of T3 and T4, and this is going to cause hyperthyroidism called Graves' disease. Now, Graves' disease is a hyperthyroidism state caused by the presence of antibodies. That's all for today. Thank you for listening.